Thanks very much, everyone, for joining us with our ANZONA webinar. What we're going to be discussing today is the management of spinal cord injuries. It's an absolutely huge topic, and what I'm just going to do today is a bit of an overview, just to give us a bit of a taste of some of the information to do with spinal injuries. We'll very briefly go over mechanisms of injury, particularly when we have a little look at some x-rays a little bit later on. We'll look at the signs and symptoms that might suggest someone's had a spinal injury, and what we're going to focus on is the collaborative management, but particularly the initial management in the first 24 to 48 hours of getting a patient in who's got a spinal cord injury. One of the really important things that we need to think about is that we treat all of our trauma patients as spinal injuries until proven otherwise. So if they have had a mechanism that is suggestive of quite a lot of force, what we need to do is think about it as being a potential spinal cord injury. Patient who's had a loss of consciousness, same thing. Think about it as a potential spinal injury until we can definitively say that it's not. And particularly someone who's had a laceration or a head injury, anything that's happened there that's had a force on the head, we need to think about the cervical spine. The sort of causes that we see in these, particularly Australia and New Zealand, we see quite a lot of our spinal cord injuries are from motor vehicle accidents, diving injuries into the water. We do see them in industrial accidents and fall from heights, sports injuries, and for Australia and New Zealand, we're looking at our AFL as well as our rugby, where some of the players may be at risk of a spinal injury. And particularly in other countries around the world, not so much Australia and New Zealand, more common mechanisms that they say may be from a gunshot wound or stab wounds. But certainly here, and as well as overseas, usually alcohol's involved. And unfortunately, like a lot of our trauma patients, what it is we're seeing our young male patients between the ages of around about 16 to say 28 or 30 being the major part of spinal injuries that we see come through, because they're overrepresented, unfortunately, in our trauma population. Signs and symptoms which may suggest that someone's got a spinal injury. First of all, if they are conscious and they can report it, if they've got pain along the spine anywhere, or if we can hear or feel some crepitus in the area. If they're an unconscious patient or if they are conscious, some of the other things that we can have a little look at, which might be quite suggestive that they've actually got injury to their spinal cord, particularly cervical injuries with patients that present bradycardic, they're hypotensive. When we have a little look to assess any reflexes, those reflexes are absent. They may appear to have a flaccid paralysis at that stage. They may be able to report to us a loss of sensation and also motor power. Patients that have been out in the environment with spinal cord injury also take on the temperature of the environment around them, so we see the poikilothermia with that as well. So just unable to, with your homeostasis, maintain your own temperature. So if they've been out in a hot car, obviously they might be quite hot, or if they've been out in a cold area as well, we may find that they're really cold when they present. So that's our poikilothermia. When we look at the bradycardia and hypotension, I'll just talk about those a little bit further along the way as to how their autonomic nervous system has a role to play with that as well. The other thing to have a little look at, and certainly cervical injuries, one of the things that with an unconscious patient we want to have a little look at that might be a really good way of knowing that we've got a spinal injury is have a look at their pattern of breathing. If you're seeing someone with diaphragmatic breathing, we're not seeing their intercostals working, again, we're going to be suspecting that that person has got a cervical cord injury with that as well. And obviously, if they're not breathing at all, that is certainly could be spinal cord involvement. Assessment and classification of our spinal cord injuries, there's really, this could be a whole talk in itself because there's so many different types of incomplete lesions. And I'm not going to actually go into the incomplete lesions today, but what we're going to do is just simplify it for the purpose of this session. And basically they're classified according to their level of neurological injury. So there may be a cervical injury, a thoracic, lumbar or sacral injury. The other thing is they're classified depending on what sort of lesion that they have. Is there a complete loss of sensory and motor control, or is there an incomplete loss of either sensory or motor? So that's one other way that they can have a look at it. And as I said, the incomplete lesions, there's a whole lot of different patterns of incomplete lesions that patients present with. The other way we have a look at is which of the limbs are involved with the loss of sensation and movement. If all four limbs are involved, then we used to call it a quadriplegic and now tends to be called a tetraplegic. If it's two limbs, usually lower limbs, it's a paraplegic. That can be upper limbs as well. Certainly there's one of the incomplete lesions where patients don't have control of motor and sensory of their arms, but they do still have motor and sensation in their legs, and they're still a paraplegic as well. Hemiplegia is one side of the body. Okay, and as we see, we've got cervical, thoracic, lumbar, and sacral. One of the things I just want to point out on this, and where we can see the red part, or reddy sort of orange part, around about T12, what is it, T12L1, that's actually where the spinal cord ends, okay? Spinal cord doesn't go the whole way down into sacrum. What it does is it ends round about, in most people, somewhere between about T12 to L2. And when we have people with an upper motor neurone disorder, that usually means there's something, it's from the spinal cord upwards. And then underneath that, we have the cauda lesions as well. And usually they present as a lower motor neurone lesion. So why we treat our trauma victims all as spinal cord injuries until proven otherwise is an injury like this on the screen, very life-threatening within minutes. Okay, what we can see is a complete dislocation. I think it's C1, C2, C3, and there's complete dislocation that's happened in that. What's going to happen is we've got a patient whose respiratory centres have been knocked off, and this is minutes that this patient's got to live unless there's intervention that's happening. Now, when someone presents into an emergency department, or if you're on the scene of an accident, we're not going to be able to see this injury. But say someone's got a really mangled limb, looks absolutely horrible, they've got a lovely open fracture to see, that may be what quickly draws our attention, but it's cervical spine and it's cervical injury that is really prioritising the care. Now, when we look at mechanisms of injury, that's not a very good x-ray at all for patients, and you will see people that come through with x-rays like this. When we look at mechanisms of injury for the cervical spine, and I want you to picture someone that's in a motor vehicle accident, when we flex our cervical spine forward into a forward position, and at the same time there's sort of a lateral force, rotational force that happens, that's what opens up those facet joints to allow the dislocation from happening. So a nasty injury like you can see on the screen at the moment would most likely have been a flexion rotation to allow that from happening. Now, if we can imagine where that spinal cord is travelling at the moment, you can see certainly that that's very, very nasty. One of the things to remember, C3, 4, 5 keep us alive. So that's where diaphragm is innervated by and all of our respiratory centres. Intercostals are a lot lower down, and certainly our abdominals, we're getting right down into our thoracic areas until we've got innervation of our abdominals. But diaphragm straight away has not being innervated through a injury like that. So remember, C3, 4, 5 keeps us alive. The other thing one of the ICU consultants told me one year was it's S234 that keeps our guts off the floor. Okay, and that's what we look at with our continence, so right at the other end. That's always allowed me to remember it. Okay, a little bit lower with a cervical spine injury, not quite as nasty looking, but certainly this could be a cleat dislocation and lesion as well, much further down the cervical spine. Again, because it's a dislocation and it's moved forward, it's quite suggestive that someone's been in a fixed and rotated position to allow that to dislocate. We do see thoracic injuries as well. This is a very nasty one. Thoracic vertebrae don't dislocate quite so easily as our cervical spine does, because what happens is we've got a lovely rib cage acting like a ring and a protector around all of our spine because of that area, and it works like a really nice brace for thoracic. So that's why we don't see thoracic dislocations quite so often. When you do see something like this one on the screen, what you do know is that it's really taken a very high velocity force to be able to cause a thoracic dislocation. So any thoracic dislocation, straight away think about all of the organs that are sitting within that rib cage that have also been prone to that same amount of force. We'd be looking at a multi-trauma patient. We would be thinking that somebody's really quite potentially hypovolemically unstable within that time as well, and they're very nasty. And as we can see with the lumbar region below that, that's not protected as well with a lovely rib cage, so that's much more prone as the cervical spine is to fractures and dislocation as well. It's not always flexion and rotation that causes it. It can be extension that causes those injuries too, particularly in our elderly. If you imagine someone that's had a fall forwards, they've hit their chin and moved back, that's quite often how we will see some extension injuries happening, and also compression injuries. And we've got an example of a compression injury here of L1. What's happened is somebody's had a fall of some sort. It may have even been a fall onto their feet, and that's causing compression and a burst fracture. And as you can see, as it bursts, that may burst into that spinal cord area just in here as well. Doesn't look like, as you can see, the spinal cord's not severed, but that may be enough impingement to have caused a complete loss of sensory and motor. So once they actually do some testing, they would know what level, what sort of injuries happened. And just another example of that as well, we can see that there's been a lot of compression down on that T12 L1 area. They've ended up nice and jammed together. One of the things I will say is if you have ever a patient that presents with bilateral calcaneal fractures, always think lumbar spine, because quite often those forces that have caused, a fall on their feet, enough to crush their calcaneum, then what will happen is that will transfer right up, and quite often there is an associated lumbar injury with that, such as compression fractures as well. So always have a high level of suspicion. They may only be complaining about their feet, but at the same time, check lumbar spine too. Okay, so that's sort of just a quick run through of some of the different types of injuries that we see. What we're going to do now is we're going to look at the assessment and also the management of a patient with spinal cord injury. And what I'll do for simplification of the session is we will assume that it's someone that's got a complete injury with complete loss of motor and sensory. And for example, can I confirm that you cannot hear all the noise in my house? No, Cheryl, we can't hear, that's fine. Okay, what we will do is we'll also assume spinal cervical injuries and work our way down with that as well. Okay, first thing we want to do, as we've said, we've got high level of suspicion from a trauma patient. So one of the things we want to do is if cervical spine is suspected, then we want to be immobilising the cervical spine. What I've got up on the screen at the moment is one of the types of collars that we use quite commonly. Most people will probably be already familiar with the Philadelphia collars, which we've used for a long time. And what I'm showing here is the Miami J collars. We personally just get them supplied by AOT, which is one of the reps that we have over here. And they're a lot easier to try and fit, and they're really quite padded and comfortable for the patients. So we're tending to use those a lot more now than the Philly collars for them. Is anybody else using the Miami J's? I'll just give people a couple of minutes. You're still using the Phillies? Yep. And sometimes the Aspens. Yep. Okay. Okay, so there's several types of cervical immobilisation collars that are available. The principles of using them are all very, very similar. It just may be that the measurement and the adjustment from each other is certainly different. But what we want to do is making sure somehow that we've got that cervical spine immobilised. Yep, Miriana's saying Philly for 48 hours until flexion extension imaging is done. Okay, so high level of suspicion, what we're doing is wanting to immobilise. If you're in a setting which you don't have collars that are available like this, sandbags can work very, very well for trying to immobilise the patient's head. And in a first aid situation, it may even be some newspapers that you can try and fold over and roll up and try and, fashion some sort of collar to be able to create the cervical immobilisation for that as well. You've seen the Philly collar put on upside down and back to front. Yeah, this one looks like it'll be harder to do. That is, yeah, I think so too. I think it's harder to actually get a little bit wrong. Okay, and the other thing too, and I've got a slide right at the end, is the AOT website is really, really good with the instructions on how to put the collars on. They've actually got a really good section on, how to sort out how to measure the collars, put them on. And I would suggest that probably quite a lot of the companies that supply any of the different types of cervical collars, usually if you go onto their websites, they have some very good resources for that. Okay, when the other thing we're doing is if we're immobilising someone with spinal cord precautions, is making sure that they're lying flat, and that any time that we're moving them around, what we're doing is making sure that we're maintaining alignment with a log roll with the patients until, as we say, we can prove otherwise or confirm whether they have a spinal injury. Okay, the return of function depends on quite a few things. First of all, the extent of tissue destruction to the spinal cord. It's very, very hard to see on plain films unless you get a really obvious one like the ones that I've already shown. But what happens is someone can have a really nasty looking cervical x-ray and they'll have no deficits, and somebody else can have an x-ray that looks really not too bad and they've got a complete deficit. So a big part of it is also our assessment of the patient. But one of the things is when the person's had the mechanism of injury, we don't know what position the spine has moved into before it snapped back into the position that we're seeing on the x-ray. The other thing is the spinal foramina, which our spinal cord travels down. Some people's spinal cord actually fills pretty much the whole foramina, and other people have got quite a lot of movement and a much smaller spinal cord and a much bigger foramina that allows them a little bit more room to move in an injury, if that makes sense. The other thing we have a look at return to function is the sort of precautions that are taken. And obviously we do want to be very, very careful and make sure spinal precautions are looked after. But at the same time, we shouldn't be fearful of actually touching the patient or providing something like pressure area care, because we're so worried that if they're going to move a small amount that we're going to do more harm. Okay, you think again, right back to that mechanism of injury. It's taken a lot of force to allow that injury to happen. It's actually a very rare situation that you might have bone within millimetres of the spinal cord that you're going to create more damage. If we're taking good precautions, making sure we're log rolling the patient, we're looking at their alignment, chances are that they won't sustain more injury just from us trying to do something like pressure area care. I've been in a couple of situations where patients have been transferred, and they've been transferred from an area where staff are really nervous of touching them, so they've left them flat on their back for hours, quite a lot of hours at a time, and certainly that's a worry as well, and it has been because they haven't been comfortable to touch them and they've worried that they're going to cause more harm than good. But it is really rare for more injury to happen just in normal sort of log rolling of the patient. One time that I did see a patient whose deficit increased was actually a gentleman that we had in one of our wards, and he was in halo traction, and he had an incomplete lesion. And what happened was he was a Vietnam vet, and during the night while he was asleep he had a really, really nasty flashback nightmare. He didn't know what the halo traction was, and he actually threw himself out of the bed, and he was found on the floor sort of hanging from his halo traction. And certainly in that situation it was enough force to cause more trouble, and his deficit did increase as well. And it was just one of those unforeseen things that the staff couldn't have anticipated for happening. Okay, prevention of complications. Again, the more complications that we can prevent, and again, like any of our trauma patients, avoiding hypotension, avoiding hypovolemia, making sure our patient is well oxygenated, all those sort of bits and pieces can make a very big difference to the health of the spinal cord to allow preservation of as much function as we can possibly have. One of the key points when we look at the management, and certainly when we look at the respiratory management, it's just like any tissues of the body. Once they're injured, they will still bleed, they will still swell, we'll still get that edema happening within the area. There's a inflammatory response, just like any of our tissues, happening within the spinal cord as a part of that injury. So what will happen is what level that they come in with deficit, you should expect that it may ascend 1 to 2 levels within that first 24 hours. Why this is really, really important is, imagine we say C3, 4, 5 keeps us alive. You've had a patient that's come in showing on assessment that their level, their deficit is around about C6. They're breathing spontaneously at that age. They've only got to ascend 1 more level up, and we're moving into their respiratory centres. And certainly if someone's that close to C3, 4, 5, we should be watching and assessing really closely and maybe anticipating that that could happen for our patients, that they will ascend. So respiratory, one of the key things, deterioration, as I said, is really common. What we need to remember that's come in with a spinal cord injury, diminished function of their diaphragm if they're, as we said, C3, 4, 5. Intercostals are not starting to be innervated until we're into our thoracic region, and our abdominals are much lower. Things like our abdominals, that's what's happening, helping us to get enough force to be able to cough. Intercostals, again, getting enough air into our lungs, and all of these have been affected by spinal cord injury. The other thing is they've got a really decreased vital capacity. Now, usually an adult without a spinal cord injury, the vital capacity, as in if we take a great big breath in, blow it out as hard as we can, and how much litres we hold, our capacity should be around about 4 to 5 litres. What we would expect is someone that's got a spinal cord injury where intercostals have been affected. A normal vital capacity for someone that's come in with a cervical injury would be around about 1 litre. Okay, 1 to 1.5 litres will be their new normal value for their vital capacity. Okay, Paul's heading off. Yep, I'll finish the session. Yep, when we're done. Thanks, Paul. Okay, so what we'll do is we know that that vital capacity has been very much affected with the patients. How to make the decision as to do we ventilate these patients, do we not, is if vital capacity is getting below around about 1 litre, there may be a decision that it would actually be better for the person's oxygenation to think about ventilating them. The other thing is having a look at what their ABGs are doing. Vital capacity is really quite a good thing to have a look at because it's an easy thing, if we've got the spirometer, for us to be able to measure fairly easily wherever we are without needing the technology or the results coming back from ABGs. Cardiovascular, what will happen is when we think about our autonomic nervous system, and as we know that's made up of our sympathetic nervous system and our parasympathetic, what happens is all of our sympathetic nervous system comes flowing out of the spinal cord, starting around about T4, moving down through our thoracic and our lumbar areas. So any of the lesions that have happened above T6 have knocked out all of that outflow area of the sympathetic nervous system. As we know, sympathetic nervous system is responsible for our fight or flight. So we've lost all of whatever our sympathetic nervous system does. And because of that outflow being affected, that's why we're seeing patients who are presenting with levels above T6 and usually above T4 being bradycardic and also hypotensive. And again, what's happening is that's their new normal for their homeostasis and for their all of anything that's to do with our sympathetic nervous system has been affected. Parasympathetic at the same time isn't affected because the outflow of parasympathetic, which is our sleep and calm everything down sort of nervous system for rest, all comes out of the cranial nerves. So it would have to be a very, very high lesion to have that affected. What happens is we lose a lot of that vascular control, and we see hypotension and bradycardia. And certainly patients that are cervical injuries will continue throughout their life to be hypotensive and bradycardic as well. And their body just needs time to adjust to that new for them. The link to the Injury Association have got an international standards worksheet, which is a really, really great worksheet. Actually, I'll show you on the next. On here, be able to spinal cord injury, and also, be able. I'll just give it a minute just to see if that you're losing sound as well. Okay, I've just reset that now. Can you guys let me know if you can hear? I've just reset it, so hopefully but also certainly that's the way that we're classifying our injuries to be able to communicate that through areas as well as to the levels. Okay, with our neurological assessment, the other thing is a set of full neurological observations. Around about 40% of patients who've had a spinal cord injury have an associated head injury as well. So we need to be keeping an eye out on that. And also checking their neurovascular observations for that patient too. Okay, you might have missed it, but what I've got is on my last slide, I've actually got a link that you can have a look at to get that worksheet and that ASIA website up. Okay, the other thing that we said before is patient being poikilothermic, what we need to be doing straight away, checking their temperature to see if it has been affected because body's just not able to maintain its own temperature, again because of the nervous system being sympathetic nervous system being involved. So what will happen is we need to control the temperature of the environment around them and be very careful to be able to do that because any changes in temperature around them and the body temperature is going to change too. Once we move into the medical management, there's quite a bit of debate as to whether it's best to treat spinal cord injuries conservatively or whether to surgically manage. And I'll ask you guys at this point what you're tending to see within your clinical areas, whether they tend to go conservative or whether they're tending to go surgical. So I'll give you a second. Okay, we've got typing happening. Okay, conservative with a brace if necessary. More conservative. Okay, we've got different spinal consultants that have got quite different views on it, and PEDS tends to be conservative as well and transferred to spinal specialty unit. Yep, so you don't have them for a long time. So that's a really, really important point. Wherever you're working, one of the things that does make a big difference for outcomes for these patients is that if they can be transferred to a specialty unit soon as possible, that certainly does help the outcomes because it is such a specialised type of care for being able to do that as well. Now, with the conservative versus the surgical, one of the feelings of thought to support surgical management of it is particularly in those cases where a patient may have an incomplete lesion and they do have some sensory or motor areas that have been preserved and that they feel that going in for patients with the incomplete lesions may be really good to try and immobilise that area to try and conserve the areas innervated that they have got. Okay, the other feeling is if they've got a complete lesion and you've got an X-ray like those ones much earlier, where you know that the prognosis for that injury really isn't too positive at all, what you're having a look at is that the damage has already happened. Is there any benefit for them to go in surgically to try and immobilise that area, or has the damage been done? So there are a couple of the different ways of thought. If you've got a very unstable spine and a person has got areas that are still working, obviously that might be part of their decision making because they really want to make sure that no further damage is done within that. The other thing for conservative management, because we're treating the patients in bed, is when we look at that hypotension and the bradycardia and their new normal as far as all of their cardiac output goes, one of the feelings is that 4 to 6 to 8 weeks in bed, managing them, for example, in halo traction, is giving their body a chance to actually get used to their new blood pressure, all of those bits and pieces. Whereas if they're surgically managed and we try and get them up too quickly into a wheelchair, it's very, very difficult for their bodies and their homeostasis to keep up with it. So there's some of the debates that do happen regarding that. As we can see, we've got halo traction here, and this is one of the things that may be used particularly for a very unstable cervical spine and dislocations, that they can manage them within the halo traction. If they're a little bit more stable, but still some instability, and certainly further down the track, what they may choose to do is to move them over into a halo vest. And some patients that have got an unstable fracture but no deficits may be sent home to manage and do their healing at home within a halo vest as well. And as we say, there's a whole lot of different ranges of braces and jackets and bits and pieces that are out there available depending on your level of injury, but also depending on your level of stability or instability for the injury as well. Okay, some of the other things that we have a little look at with our collaborative management, first of all, hydration being really, really important, but still being managed from the point of view as we know these patients are really respiratory compromised. The last thing we want to do is to overload that patient, be causing a pulmonary edema that is going to further impact their respiratory status, and that may be the difference between them coping and not coping as well. So if there is a chance, what they do tend to do is just run them a little bit more on the drier side rather than the overhydrated side as well. Gastrointestinally, again, we know our sympathetic nervous system has been shut down, and it's the sympathetic nervous system that is responsible for our gut motility. So we'd be expecting that that has been shut down for that time. So it's keeping an eye on all of that to see whether there is bowel sounds and whether there's movement happening in the station there. Genitourinary, what we want to be doing is protecting the bladder function for the patient. Again, if they've got a complete lesion, they may not have sensation and motor control within that area, but a bladder can be retrained along the track once the reflex arc comes back. So what we want to do is make sure that the bladder is not being over-distended so that patients can take part in bladder training further down the track as well. They've got an upper motor neurone lesion where it is possible. The other thing with catheterization of the patients is certainly because they're hypotensive, if a patient is going into a hypovolemia, we're not going to see, because of their sympathetic nervous system, those signs and symptoms of a patient that's going into shock or who's hemodynamically unstable. So it's their urinary, measures their urinary output, which is going to allow us to be able to assess that. So it's another really important reason for them to have an indwelling catheter within that initial time so that we can assess what's happening with that patient. We need to keep in mind, because of all of that vascular pooling and also the immobility, that they're at risk of VTE. The only other thing is, with the anticoagulants, do we want to risk more bleeding within the spinal cord and the injury that's happening at the time? So that's a balancing act that they need to decide what they're going to do, or maybe look at some non-pharmacological prophylaxis for VTE. One of the other things that's been used quite a lot in the past is steroids, because they felt that it may reduce the swelling around the spinal cord. And I know certainly when I was working in the spinal unit a few years ago, it used to be standard for patients to go onto methylprednisolone for about the first 24, 48 hours via infusion to try and improve the outcomes for the patients. I'm not seeing this used, and I haven't seen it used for quite a few years now, and it seems to be very much out of favour because of the risk of steroids with the patients. and also at the same time balancing it that there wasn't enough evidence to say that they were actually improving the outcomes for the patients. At the moment, it seems very much out of favour, but that can be something, that may change in future with that. Posturing of the patient, making sure that their spinal alignment is maintained. If in doubt, we always put them in a neutral position so that their head and their thoracic spine are in line, straight flat on a bed, and that will be a neutral position. The other thing is if you can put a neck roll in just to support their neck with that. Once they're in an area that's experienced with the spinal injuries, they will formally start posturing them. And what they do is they posture them into the opposite of what was their mechanism of injury. So when we looked at those cervical x-rays at the beginning and saw, right, that was a flexion style injury, to be able to treat that dislocation, what they would do would be raise up the thoracic pillows and extend their head back to try and reduce the dislocation and put them in those areas. So that's something that they will do on a spinal unit. Skin care is really, really important. Again, wherever you are working, particularly thinking about their sacrum, thinking about any of those areas around their bottom, they're going to be sitting on that for the rest of their lives. So we really want to make sure that all of that skin is preserved really well for them. And I've seen some pretty shocking pressure areas in the past with patients. And once they start to get a pressure area in that area, that's something that they'd be dealing with on again, off again, on again for many years, because they just can't get off it. Then they're sitting on it. It tends to break down, and quite often they need quite a lot of plastics done as well. So within that initial part of the injury, we need to be thinking about it straight away, log rolling the patients, checking their skin, and making sure that we're doing really regular pressure area care for them. The other thing is the occiput, particularly when we talk about cervical collars, and I've seen some really nasty pressure areas on the occiput. And usually what that is due to a collar that's not fitting properly, or one that's been left on there and isn't checked. Oh, sorry, I've got to move that fine out of the area. Sorry about that, guys. Yep, so making sure that we're checking occiput as well and making sure that the collars fit really well. Analgesia for the patient, and again, doing that nice and carefully because we want to be thinking about their respiratory status and not causing more respiratory compromise for them. One of the other things we can do, and it's really quite important right from the initial phase of the injury, is hand splints. Okay, and I'll just bring one up. This is actually not the best example of a hand splint, but it was one of the ones that I could find on the internet to copy the picture. In this case, I'd be really quite worried about those straps and pressure areas. But the reason I've used this one is just to show you the hand position, because the hand position is really important in patients with cervical injuries and a complete deficit. Further along the track, when they've got, when there's someone that's a tetraplegic, if they want to be able to use splints to be able to do something like clean their teeth, hold utensils, what they need to do is have what they call a tenodesis grip. And so that when all of the contractions happen within their hands as part of their paralysis, that it contracts into a really functional position that they can work with a lot further down the track as far as their rehab goes, and teaching them to adapt, with new skills. When we see this hand position, because we can see there's a thumb and fingers can still be opposed within that tenodesis grip. Worst thing you can actually do is for a patient that is a tetraplegic is actually stretch out their fingers and put their fingers flat. And you think about any time we're lying on the bed, that is the natural position to try and put our hand, is to put our hand flat. And if the contractions happen into a flat position, that's a hand that can no longer be used as far as splints, different bits and pieces along the back. So as soon as we can, whichever setting that you're in, if we can get a physio or maybe an OT or someone with experience to come in and be able to do them a hand splint, because the contractions are going to be happening very much early on in the piece, we can give them a nice, functional hand position that they can work with much further down the track. What we used to do was we put the arm splints on 2 hours on, 2 hours off, and any time that their arm splints are on, the thumb and hand can be pointing down towards the bed. And then what we would do is when arm splints are off or hand splints are off, we just rotate their shoulder and turn the hand up the other way. And again, that will rest in that tenodesis position as well. Sounds like something really minimal from an acute point of view when we're worrying about everything we need to do. But from a functional point of view, it's something that makes a big difference. And obviously anything at the psychosocial support, starting straight away for that patient and for that family and the traumatic time that they're going through. And certainly if we can have people that support with that, that helps a lot. Okay, what can we expect along the track for some of these patients? On complete injury above C5, usually C4 and above, we'll look at a patient that's totally dependent, their ventilation's compromised, certainly C2, C3, maybe some C4 are going to possibly be ventilator dependent, or they will be ventilator dependent. It's around about C4, C5, there'll be a little bit of variation with patients as to whether they will be ventilator dependent or not. Once they get to C5, that's when they can start to actually be able to direct an electric wheelchair on their own. C6, again, if they've got that functional hand position and that tenodesis grip, that's when splints can be made. Someone can start being able to feed themselves and clean their own teeth. So just within those couple of levels, as I said, the difference between having a hand in a functional position can make such a big different outcome for the patients with involvement in their own ADLs. Cervical C7 to T1, that's when they start to get enough upper limb control to be able to push a manual wheelchair. They can start writing, much more involved with their personal care activities, and also hand controls and driving kicks in round about those levels as well, that cars can be adapted for them. And again, as you can imagine, the level of independence that brings really does improve. Functional expectations for thoracic from T2 to T12, they may be able to stand in some sort of brace. Lumbar, around about L2 is when we start to get flexion back in our hips. L5 is when they can start to possibly walk with below knee splints and crutches. Sacral, it's not till we get right down to C3 that we get normal ambulation available. And it's S2, S5, that's when bladder, bowel and our sexual functioning. As we said, S2, 3, 4, keep our ducks off the floor. But that's when bladder and bowel return for those patients. Interestingly, we used to have, I worked rehab as well with spinal, so we would have spinal patients that came in 20, 30, even further years down the track. And when you had a little chat to them about, you'd say, well, look, if the research came out, would you want to be able to walk again? And it sounds like a really obvious question. Most of them said to me, look, if we could choose anything, it would be to have control of bladder and bowel. Okay, we would give up walking to be able to control our bladder and bowel. So that's, a big, big thing for them to be able to do. And certainly there is ways that it can be trained, but bladder and bowel need retraining, and, that is very, very low. Some patients get sacral sparing that are very, very lucky that they may actually be a high tetraplegic, but sacral for some reason will be spared and they may have control of bladder and bowel in those cases. But that gives you a little bit of an idea of the functional expectations along the way. Some of the handy links, the American Spinal Injury Association, the ASIA, which provided that wonderful worksheet that you can use for assessing, and as I said, looking at motor and sensory examination, a step-by-step approach. They've also got learning modules on their website, and it's a really, really good website. The next one I've put down is the association for the orthotics people. Um, Anytime that you need patients that are in, for example, a cervical collar, as we've said, Philly collars, they're not easy to measure, they're not easy to fit. Some patients are just about impossible to try and fit a collar on. For example, some of your rugby patients that have got, these huge necks that just don't fit any of the collars that you have available to you. If you can get an orthotics person in, particularly if someone's going to be staying in a collar or a brace long term, after that initial time, if you have the availability of orthotics, then please get them involved. What I've done is I've put the Orthotics Association's website on there. They've got a little find a practitioner. You just put your suburb and your postcode in, and it will tell you where the nearest orthotics people are. Major teaching hospitals may be lucky enough that they've got their own department of orthotics that can come, but I can't emphasise enough, if you do have that availability, please do use them because it makes a big, big difference. The third one is AO Tech, and I found their website is very, very handy. And again, probably most of the companies that are supplying the different collars and bits and pieces, have a little look up to see what learning resources that they've got available, because quite often there are some really good instructions with that. So that's some of the things that I hope will be handy for you. And just a last thing, a little ad here to say that I hope that we will see you all in Sydney. I'm looking very much forward to the ANZONA conference in November, and please encourage as many people from your areas to come along because it will be really, really worth it. The program looks fantastic, and congratulations to the New South Wales people that are putting it together and are doing a really great job with it. So what I'll do is I'll just stay online for a few minutes just to see if there are any questions at all. Thanks very much, Natalie. I hope that that's been helpful for you. Thanks, Cheryl, and thanks, Miliana. The first one that you've done live. Glad that you could make it. Yeah, not a problem with advertising the conference because we've got quite a lot of WA people coming across, and we're very much looking forward to it. Okay, thanks very much. If there's no further questions, we'll end the session, and we've got Cheryl typing. Okay, thanks very much, Cheryl. Yeah, we'll end the session, and there'll be another webinar in around about a month's time. Keep an eye on the Facebook site, and we'll provide further details for you as well.